Oh, we need to record.
It started.
It is started?
Yes, just started.
Okay, perfect. Okay, so it's on personality disorders, trauma, and addiction. And I'm Natalie, and we have Sherrice with us here today, too.
Good morning.
Okay, this is the contents of the exam. And again, like all of your exams, the questions are going to be focused on these essential topics of each of them. So you have the personality disorders again, trauma and addiction. The ones that are highlighted here or underscored here are the ones that you'll see on the exam. Okay, so first up is personality disorders. And there might be one or two of you out there that might know who this is and why I put this on here. So Crazy Ex-Girlfriend is a show that surprisingly is about mental health. And you don't know that going into the show. I thought it was just like some quirky, musical, funny show. Sorry, I hope you guys did not just hear that going off my text. And by the third season, you realize, oh, this is actually something heavier when she gets this diagnosis of having borderline personality disorder. We're going to talk a little bit more about that, but we'll go into all of the personality disorders that you need to cover. So these are the different clusters of the personality disorders. You have cluster A, which is eccentric, including paranoid, schizoid, and schizotypal. And we kind of covered those in the last exam review. So those are basically the, not subtypes, but they're the schizophrenic spectrum disorders. So they have features of schizophrenia. You don't have to go too deep into those. We'll cover schizoid a bit, but just know these general clusters as well. You have cluster B, which is erratic, and that's going to include borderline, narcissistic, histrionic, and antisocial. You're going to have cluster C, which is going to be the anxious disorders, including avoidant personality disorder, dependent personality disorder, and obsessive compulsive. The cluster C's are kind of the least impeding on one's life. Those people can generally function pretty okay. What do you guys think is the most severe, most impeding, most problematic to treat of these disorders? One particular disorder. Go ahead and put it in the chat. So I'm looking for one particular personality disorder. It's not going to be OCD or antisocial. Borderline, yes, Michelle. It's going to be borderline personality disorder. It's the hardest to treat. Yeah, good job. But in general, cluster A and cluster B tend to be more problematic than cluster C. Okay, so we have schizoid personality disorder. Sherrice, why don't you go ahead and read this one?
Sure. Can everybody hear me okay?
Yep, we can hear you.
Yes, so we have schizoid. Thank you, Andrea. So these patients, they're not going to desire close relationships with others. Some of those typical kind of human relationships that a lot of people crave, they're not going to want those close relationships to others. They're seen as more emotionally detached, also seen as loners. So you'll see descriptions of these patients just keeping to themselves, not trying to be overly friendly and join in group activities and things like that. So interventions, when we're going to be talking to these kinds of patients, we want to avoid overly friendly interaction. We want to give them a proper amount of space, respect their need for social isolation. We don't want them to feel uncomfortable, especially in the initial period as well. We also do not want to try to increase socialization. We don't want to just abruptly try to, get them to want these close relationships. It takes more than that. It takes a combination of psychotherapy, group therapy, and antidepressants. And you guys will see throughout this whole slideshow that for many of these, the most effective type of treatment is the combination of medication and psychotherapy as well. That's the best way to treat all of these mental disorders.
Awesome job. Okay, so borderline personality disorder. It's patterns of marked instability in emotional regulation, known as dysregulation, impulsivity, identity, unstable mood. Unstable interpersonal relationships as well. Oh, yeah, that's a big one with borderline personality disorder. So, additional features would be emotional lability, fear of rejection, fear of separation or being alone. So, that's why they often cling to people and gain like obsessions with people. Self-destructive behavior. They may have self-harm behavior, like self-mutilation, and then they will have attention-seeking behavior. Splitting is a primary coping mechanism of these individuals. It is the inability to incorporate positive and negative aspects of oneself or others into the whole picture. So the individual may tend to idealize another person at the start of a new relationship and hope that this person will meet all of his or her needs. At first disappointment or frustration with this person, however, the individual quickly shifts to devaluation, despising the other person. Oh, I just got a notification that you were able to upgrade and get us unlimited time. Did you?
Yeah, I was working
Awesome.
on something in the background and I figured we have this review and another review. So I just went ahead and just got the monthly plan.
Oh, girl. Well, that is fantastic that we don't have to. Everyone thanks Sherrice. That was super kind.
Yeah, no worries, guys. I know how it is. Like, especially like you guys are already online. You have to go through so much. Like, let this not be another stressor on you.
That's awesome. Now, perfect. We can just keep going with this.
Yep.
Okay, so again, I have a little snippet here of Crazy Ex-Girlfriend show. So, a little background. The main character of the show, this girl, she was in the beginning on the streets of New York, and then she bumps into this guy who was her like childhood little sweetheart from summer camp that she had an infatuation with. And sparks fly in her head, and you think that at the time that it's just like this cute show and she just infatuated with him, but he discloses to her that he moved out to West Covina and it's so amazing and great, and talks it up, and he's like, if you're ever out there, look me up, the same thing anyone would say to like a past friend or whatnot. But she takes it as like this invitation to uproot her life, follow him out there. She moves out there with like nothing and starts to stalk him. And meanwhile, he is in a serious relationship with another woman. She kind of breaks that apart down the road into the series, is able to get a relationship with him. But then the second that something he does is not okay with her, doesn't sit right with her, again, at that moment of frustration or like the person that they're obsessive with does something that doesn't sit right with them, they kind of just do a 180. And so she goes crazy basically in the show. I shouldn't say crazy, but that's they're very just unstable. And so yeah, sorry, I'm totally butchering this. I think it's because it's recording. Okay, Sherrice, why don't you go ahead and take interventions and treatment?
Sure. Yes. So interventions, the nursing interventions, super important. boundaries. And I say that so many times because it's really important when we're approaching these patients to respect those boundaries and also be aware of their manipulative behaviors. A lot of times, like, I don't know how much clinical exposure you guys got, but like they will walk up to you and I'll be like, hey, like, wanting to be super friendly. And then they'll start, requesting things from you or trying to be manipulative with you. So just kind of be aware of that in your interactions with them. Clear, straightforward communications, like keep it straight, short, sweet, and to the point is what I was trying to say. And then also assess these patients for suicidal or self-mutilating behaviors. Okay. So the treatment that we're going to give to these patients is going to be usually short-term hospitalization. So I'm sure you guys are familiar with 5150, especially if the patients are assessed for harming themselves or harm to others. There's also CBT, which is cognitive behavioral therapy. DBT, which is dialectical behavioral therapy, talks about communicating between staying more in your wise mind versus your emotional mind. There's also something called schema. Which this is a more focused therapy. It's a combination of CBT and another therapy that's on self-perception for these patients. And then, as I mentioned before, most effective treatment is going to be the combination of therapy and pharmacological treatments. So we can prescribe these, well, we won't be prescribing, but the physicians may prescribe for these patients anticonvulsant mood stabilizers, lithium, antidepressants, omega-3 supplements, naltrexone, and second generation antipsychotics.
Awesome job. And then just to piggyback on the pharmacological Ds, different meds or supplements are targeting different aspects of BPD because there's a wide range of symptoms that they experience. Great job. Okay, so narcissistic personality disorder. So I just added this image last minute because I just wanted, for those of you who don't know, I really love Greek mythology, but for those of you who don't know, the word narcissus was driven from the Greek mythology of Narcissus. And basically, he was this person who was notoriously good looking, but he had an elated sense of self, was obsessed with himself, and then eventually fell in love with his own reflection in the water. So I just thought that would be fun to put there. So narcissistic personality disorder is characterized by feelings of being entitled, an exaggerated belief in one's own importance, and lack of empathy. In reality, people with this disorder actually suffer from weak self-esteem and hypersensitivity to criticism. So you guys might be able to think of some people in your life that may identify with this. It's pretty common to see. And also it has features of grandiosity and self-importance. Some interventions for these people are keep neutral with the patient. And then these last three are really important. So provide role model empathy, but also convey confidence to these people while at the same time avoiding power struggles. So treatment would include, always comes back to the cognitive behavioral therapy for most, also group therapy. They may be on lithium if they do have mood swings, and they may take antidepressants if they have depressive symptoms. Okay, so antisocial personality disorder. Sherrice, I'll let you go ahead and take that one.
Yeah. So we have antisocial personality disorder, also known as ASD. So this is going to be characterized by our patients, usually a pattern over time. They have a disregard for and violation of the rights of others. So they're going to have like being really hostile, angry, and unfriendly, trying to be, I like to call it sketchy, but being kind of shifty and shady, deceitful. They also can be very manipulative. So not to be confused with BPD. These patients have a lot of these symptoms, but it's not as chronic as it is with or not chronic, I should say, but is not as extreme as some of the BPD symptoms. This is more like just kind of being avoidant. Oh, let me see you in the chat. Let's see. You just hit okay. Oh, there's a notification covering. Is it just that notification that says like you've been upgraded to unlimited minutes? If you hit okay, it should go away. If anybody else still has it on their screen. Okay, hopefully that works. So in childhood, a risk factor
I'll
that
try to field the chat, sorry.
Oh, no worries, no worries. So a risk factor in childhood for these patients is an intense and cruel disregard for others. So like they'll call these kids antisocial, but the better word is to use they're callous. They just don't care. They don't feel remorse. They just disregard others and their feelings. So some nursing interventions we have for these patients is we want to set limits on their behavior. You'll see like in HESI, they'll describe a patient with this, or they'll explicitly say a patient has antisocial personality disorder. What would be what would be a priority nursing intervention? And so setting limits on their behavior would definitely be one of them. You also want to recognize manipulative behaviors, be aware of aggression, communicate boundaries and consequences. With a lot of these patients with ASD and BPD, setting boundaries, firm boundaries, is very important. And it's also going to make you safe and it's going to keep the patient safe. Treatment is going to be identifying a problem and behaviors that need to be addressed with therapy. They can do family therapy or milieu therapy, also known as small group therapy. For these patients, there's no specific medications. However, mood stabilizers may help with some of their symptoms. For example, their depressive symptoms, their aggressive symptoms, and some of those impulsive tendencies.
Great job. I just want to add one thing in with callousness that I didn't put here. This might also be seen in children in a way not with just disregard for others, but maybe animals as well. So
Yeah.
if you see those kids that are like, mutilating an animal, like a dead animal, or like has done something harmful to an animal, it could be seen in that way. And often those are the people that grow up to be like sociopaths, basically. If you want to associate those two. Okay. Trauma includes violence, sexual abuse, neglect, and PTSD. So PTSD, post-traumatic stress disorder, and acute stress disorder. Traumatic life events can result in a wide range of psychiatric disorders and other medical disorders. Trauma responses can be the result of tragic yet day-to-day experiences, such as prolonged and severe child abuse. Traumatic responses can also be the result from out of the ordinary horrific events such as war or disasters. So both PTSD and acute stress disorder follow a beyond normal stressful and traumatic events. So things such as natural disasters, bombings, military combat, torture or kidnap, sexual assault, but there is so many different events that this could be relative to. Know that PTSD is long-term, where acute stress disorder is short-term, and it's defined by less than a month. Okay, and Sherrice, go ahead and take PTSD and acute stress disorders, interventions, and treatment here.
So I really love how this is bolded up here because this is super, super, super important, is assessing for suicidal or violent ideation. These patients, depending on some of their treatments and medications, there can be fluctuations in how they're feeling and their emotions. And sometimes they can have a lot of energy, and that can increase the risk of suicidal ideation. It can also be when the opposite happens. So we want to constantly assess these patients for suicidal ideation. We also want to assess for any social or family support and also any functional impairment, because this can be attributing to the PTSD and the ASD. We also want to assess their current life stressors and level of anxiety, because these patients almost always have a level of anxiety, whether that be generalized anxiety disorder or, just addition to their PTSD. Some interventions are the NSESS, which I really like. I actually looked it up, and it's the National Stressful Event Survey. So it has a list of things that you can use to assess your patients. And while you're assessing them, you want to remain non-judgmental in your interactions. One thing that I identified in myself is I have a habit as I'm listening to nod my head, which I think a lot of people do. However, sometimes this can come off to patients as you are being judgmental, or maybe you're not really hearing them or listening to them, you're kind of brushing them off. So you just want to be aware of that also when in your interactions with these patients. um, Encourage an expression of their feelings, if whether that be writing. If they want to cry, encourage them to just let that out, just cry it out. If they want to do art, they can do art. Using accepting, nurturing, and empathetic communication. Again, I love that this is bolded because you may see on HESI, you have a patient who's diagnosed with PTSD and they're seen crying in the day room. How would you communicate? What type of communication would you use with this patient? And that answer would be empathetic communication. So that's super important. Okay. Also, the treatments. Again, I love this because combination of pharmacological and psychotherapeutic is the best and most effective way to treat these patients. So I'm sure you guys remember from Patho, all of these medications, but just some examples like of SSRIs would be things like Lexapro, Prozac, and Zoloft are like the most commonly seen. So remember, these ones take 2 to 4 weeks to start working, and some patients may feel side effects initially. And if they're complaining to you about the side effects, just try and reassure them. They will wear off quickly as they keep taking the medication and their body, is used to having it in their system and it reaches therapeutic levels, the side effects will start to subside. However, if they're having really, persistent, intense side effects, we can always tell the doctor to reevaluate. MAOIs, I'm sure you guys all remember this one, has all those dietary restrictions. So all the stuff that we like to indulge in from time to time, like caffeine, alcohol, chocolate, cured meats, aged cheeses, just keep those things in mind because on HESI you may see some dietary questions. SNRIs, again, patients can start to feel better after 2 weeks, but it actually takes some time for the medication to build up in their system. So we usually see effects in actually about 6 to 8 weeks. And then TCAs, things that we want to be on the alert for, especially in regards to patient safety. Always with patient safety is they have most common side effects are sedation, confusion, and orthostasis. So you want to make sure these patients rise and change positions slowly, especially if they're inpatient. They may not be eating properly. Oh no, my internet connection is unstable.
You're good, good.
Oh, good. Thank you. So yes, keep an eye out for, safety risks such as fall risks and things like that. And then yes, on the psychotherapeutic end, we have psychotherapy, psychoeducation, which includes CBT. It's kind of retraining your thinking in sort of a way. And then EMDR is a process of using light and eye movement, which is going to desensitize and reprocess a lot of triggers and things that patients with PTSD have to deal with. Yeah, and then Natalie, do you have anything to add? I don't know if I got everything.
Yeah, no, so the eye movement, desensitization, and reprocessing, they're kind of combining those past events, like thinking about them while doing that and reprocessing it to desensitize them to it. You did awesome. You speak so well all the time, which I love. The only thing that I want to say, and I meant to mention at the beginning, and Sherrice pointed it out, is that anytime you guys see that I've bolded and italicized something, it's important to know. Okay. All right. Violence, sexual abuse, child abuse, and neglect. So anger is a primal and not always logical human emotion. It can range from mild annoyance to intense fury and rage. Aggression may be appropriate or self protective, as in protecting oneself, one's family, or another individual who is being bullied. it is characterized by initiating hostilities directed at others. It can result in verbal or physical violence. So some nursing priorities, you want to have expeditious response to threats. You want to identify risk for danger to self or danger to others. I mean, that should be bolded and italicized as well, but you guys should know that like ingrained in you by now, like safety is a priority. You want to identify suspicious or angry behavior. You want to identify triggers of anger. You want to use a calm approach and remain respectful. And then in regards to sexual assault, it may result in PTSD or acute stress disorder with symptoms such as flashbacks, anxiety, depression, or suicide ideality. So any of those symptoms can be part of PTSD or acute stress disorder. If a child is abused or neglected, or if it's ever suspected that a child abuse or neglect has been present, it is a priority to report it. This is mandated reporting, and it must be reported according to state regulations. So that is going to be a major part of your job as nurses.
Yeah, and I also just wanted to put out there too, you may also see on HESI as well that when you're screening this patient, what action can you do to elicit some of the most honest responses? And this would be getting the patient into a private, quiet location away from others and away from anybody that they came in with. And just in terms of reality, as a nurse, you can say, hey, to the patient and their family, I need to do this portion alone with the patient specifically. And that usually is enough. Like, I need to do this exam alone. They'll usually leave them alone. But you guys will get more into that later on as you get into leadership and things like that.
Also, for those of you who are going into peds, do you know there is a specific age that we ask to be in with patient alone, even if we don't suspect anything. We always have a solo visitation with just that patient. Do you guys know what age that is? You're not in PH yet, so I'll just tell you, but it's 12 years old. So yeah, oh, Rosa, you got it, perfect. And Michelle, perfect, you guys. Yeah, sorry, I'm not great about opening up the chat, but yes, 12 years old, we ask the parent to step out and we're gonna have just the one-on-one with the child. But at any point, if you do suspect there is abuse, like Sherrice said, you can try to, get the patient alone and see what you can get out of them. But oftentimes they may not open up, and that's why if there's any suspicion, you just go and you report it. Okay, so addiction.
Sherrice, question, sorry, about the reporting. In some of our HASI case studies or questions, it asks us like, who do we report it to? So sometimes it's confusing because it asks like, do you report it to the authorities? You report it to the physician, and the correct answer is the charge nurse. But I just want to make sure, is that correct?
Yes, most oftentimes it'll be the charge nurse. You go up that chain of command, right? And then they'll do what they need to do to report it to authorities. But that may also vary, like I said, I don't know if I can go back. So it must be reported according to state regulations. And, each state is unique. So I would just find out what your hospital protocol is for that when you accept your job, because it's going to be an important part of your job. Know what the process should be.
Yeah.
Good question.
And I have to say, like, in all of our exit HESI so far, what I have seen, the answer almost always has been charge nurse or nurse manager.
Okay.
Yeah. So for NCLEX purposes, yes, it is the charge nurse.
Yeah.
Okay, great.
Mm-hmm.
Thank you.
Yeah. Okay. So addiction. Sherrice, you want to take addiction?
Sure. So addiction is a primary chronic disease of brain reward. It's actually also defined as a person not being able to function and do their ADLs without having that reward, that motivation of that substance. It's also a disease of dysregulation. So this is when the pleasure seeking reward pathway of the brain it's imbalanced. It's not working like it does in people like you and me that don't have this. So the qualities of remission and relapse are very much like other illnesses. You can go through phases of being in remission, and then things can happen in life. There can be adverse events that can cause a patient to relapse. And it's important to be real with these patients and let them know that that's a possibility. However, it's important to identify the tools that they have at their disposal. These patients who meet the definition of addiction are unable to abstain from substance of activity of addiction. So they're constantly, they can't keep away from it, basically, how to sum that up. And a lot of times patients are unable to identify like why. Sometimes their family members may be asking, why did they do this? Why did this happen? And the patients themselves can have a hard time identifying this. And this is when therapy, especially psychotherapy, comes in to help a lot for these patients. So a couple more definitions here. We have intoxication, using a substance in excess, tolerance, no longer responding in a way that they initially did to the substance. They need more of the substance. It takes higher doses to achieve that previous response. Um, Essentially that means it takes more to achieve that euphoric level. So they can feel really crappy, and then they use more of the substance, they feel kind of okay, like they can function with the day throughout the day, but they always want to chase that euphoria, so they want to use higher doses of that medication to achieve that feeling. And then there's also withdrawal. So this is specific to the substance. It begins when the substance is ceased, and it may be mild and up to life-threatening. Okay. And I think, yeah, we're going to go into that more in depth in her next slide.
Great job. Okay, so nursing priorities with addiction. So for assessment and interventions, you want to do accurate assessments of their pain in relation to the tolerance. Be aware that with the other healthcare team members, often people can use countertransference when they have patients that come in with pain and they're, seeking out medications. I've actually experienced this myself in the ED with one young girl who was admitted because she was having feeding tube problems. She basically was failure to thrive, and they were trying. She was at Herrick in the AM. They were trying to get an NG tube in. They couldn't get it in, so she was admitted to the ER because they needed to get some sort of substance into her. So come to find out, like the doctor kept saying, give her more Versed, give her more Versed. And then all of a sudden my nurse made a comment to me, oh, okay, she's a junkie. She's seeking drugs. And it bothered me because she clearly had a tolerance. And we don't know all the time the entire history of a patient. And this girl was such a sweet young girl. She was in there reading her book. Like, she was a smart girl. Like, I had conversations with her. But she had failure to thrive. She had anorexia, and they probably have to tube her all the time. So even that little bit of Versed, which Versed, for those of you who don't know, it's a pretty heavy duty sedative. But she needed more of it because they probably are doing it all the time. But my nurse made this comment, and that was probably countertransference, where she may have known someone, or just maybe like throughout time, you get that nurse burnout of being in the ED, seeing people who are coming in with substance abuse problems. But it was sad to me because the girl was so sweet. So just be aware of that, those countertransference experiences, and people, and even doctors can make comments, and that's important to know.
They have all these pre-existing biases because we're new in the game, but they've been around for a long time, and we have this wonderful cultural shift, especially in the Bay Area. But sometimes you meet nurses that say some kind of shocking things, and you're like, okay.
Yeah. Totally. Yeah. And there's times that you're like, oh, I just don't agree with this. And keep a professional behavior, especially when you're in the student nurse role, but just, kind of just make note of it and always be autonomous in your judgment, even if, a doctor is saying like, they don't need that. They don't need that. It is your role as a nurse to do those assessments and do those accurate assessments of pain. And so we also use for assessment tools, we use the CWAS. I don't know if that's how it's pronounced, but that is the one that uses the assessment for alcohol withdrawal. And then we use the COWS, which is the opiate withdrawal scale. Those are important to know the difference between the two. Okay, so alcohol withdrawal can be life-threatening. You want to assess for visual disturbances, confusion, anxiety, tremors, diaphoresis, nausea, elevated blood pressure. They may easily startle, which is hyper-alertness, and then possibly have seizures as well. You want to de-escalate patients but with anxiety reducing measures. So use calm approaches, provide adequate personal space. So don't get too close to them, and make them feel like their anxiety is going to just shoot up if you invade their personal space, especially if they're detoxing. Offer PRNs. You want to always prioritize your ABCs. So airway, breathing, circulation, right? Prioritize this with opiate intoxication. You want to monitor for bradycardia, decreased respiratory rate, head nodding, and sedation. That should be bolded and italicized. That's important to know. If you find a patient who they're ODing, whether it be heroin or whatnot, they're ODing, you want to simultaneously get help, but you want to deliver what to them? Narcan. Yeah. So Narcan is going to immediately reverse those effects. So if their respiratory rate is dropping, their heart rate is dropping, everything is dropping, they're ODing, get that Narcan in them, stat. Okay, so you want to offer support for family members involved, patient and family, teaching on recovery as being a lifelong process, because it is, like we said in the previous slide, very similar to other major illnesses. They're gonna have periods of recovery and relapse, and that is seen very, very often with these patients with addiction. So some treatments will be cognitive behavioral therapy. That's a huge one for addiction. There will also be individual and family therapy. So like psychotherapy, talk therapy, all of that. And then medications to know. Antabuse for aversion to alcohol. So it's a drug that they take that makes them sick to alcohol. So they won't want to touch it again. Methadone for opioid or heroin withdrawal. And you'll come across that a lot in maternity, because often, we see people who are heroin addicts, they end up getting pregnant, and then we have to get them on methadone for sure. Okay, and then naltrexone is treatment for both opioid and alcohol addiction. And there is many more medications, of course, for addiction out there. Many of you probably know from your AA meetings, hearing about the different ones that people, and then even the people that are in those meetings are like, oh, this one worked better for me. And they share that with each other using those Yalom's principles, right? And then the last thing is you want to provide patient education specifically for antabuse. You want to teach them that they need to avoid products with alcohol. So any products that have alcohol content, such as mouthwash, cough medicine, and aftershave, which just was weird to me because I didn't realize that aftershave had alcohol. Not that I use aftershave, but those are important to know.
Yeah, that's super important. I love that Natalie bolded that too, because if you consume alcohol or yes, and hand sanitizer. When I worked at a chemical dependency rehab, we had to
Yep.
keep hand sanitizer behind the counters. We could not give
Yep.
it to patients. But if patients do consume alcohol containing products while taking disulfiram, they can have irregular heart rhythms, blurry vision, trouble breathing, confusion. So it's important when we're doing patient teaching that we educate the patients about just really, what am I trying to say? Emphasize that. Okay.
Can I ask you guys another question?
Yeah, shoot.
It's kind of about when we're in the hospital. You guys are in the hospital now, and you were just talking about how when you see a patient, maybe a physician or maybe even a nurse passing judgment on the patient, right? And
Yep.
we're supposed to be advocating for them. And I know that we're going to be students then, so we kind of have to like be weary of how we're behaving. So I don't really know, like, what's your recommendation for things like that? Like, what if we are in a situation that like that and we feel like the patient is being misjudged or not advocated for? Like, are we just supposed to let it go because we're students and we're in clinical and we can't really do anything about
So
it?
that's a great question. And the biggest thing I would say is if it comes to a safety concern, you need to go up the level of that chain of command. So go to the charge nurse. If you're suspecting something that is going to be problematic to the safety of the patient, then yes. What I dealt with was more of like a counter transference, and they made a comment, but it was not impeding on the patient's basically their treatment plan, because the doctor continued to say, keep giving the Versed, keep getting the Versed. And then finally she did get those slightly sedated effects, and we were able to do the NG tube, where she was calm enough to be able to do that. So I was still there with the whole process, and she was able to get the quality of care that she needed. But yes, if you see that a patient is like, you know, just being really mistreated, or they're not getting the quality of care because of safety concerns, then you would need to have a discussion with the charge nurse about that and just relay your concern. You know, you're not there to
You're not going to change their way of thinking if they've thought that way for
thank you.
60 years, you know, like you can just kind of be like in your head, like, okay, I made a note of this. And then, you know, you can do everything in your power to advocate for that patient, to make sure they get bathed, to ask them if they need anything. You can, as a student, you have the benefit of having so much time to spend with that patient. So you can really be observant and make sure they're getting a great quality of care. And just like Natalie said, if anything is affecting patient safety, you have every right to go to that charge nurse. That being said, I have had other members in my cohort that have got into, I don't want to say like anything too crazy, but you know, maybe have said something to a nurse or a physician, kind of trying to get to change their mindset, and it didn't really turn out that way. And so that's where I was like, you know, you're not going to change anybody's thinking after 50, 60 years. But like Natalie said, it's all about patient safety. You can do everything in your power to take care of that patient and advocate for that patient, because we really are the go-betweens. And we're a whole new generation of nurses entering this field with, you know, we've had the wonderful pleasure of, you know, living in the Bay Area and growing up with a lot of progressive ideas. So I think just integrate that into your practice as much as you can.
Yeah. I 100% agree, Sherrice. Like, you guys are going to learn certain things in school, and you may get into the hospital and there may be different methods of doing it. So you don't want to like overstep your boundaries and your scope of practice as a student nurse. Like, you can certainly question things, but do it in a respectful manner to your nurse. Like, for instance, like with OG tubes or intubation tubes or anything like that, like they say to market at the level of the gums, right? With nursing school, they teach you that. And that's important because you don't want to make sure it's displaced, but yet you'll see that the hospital may be measuring at the level of the lip, which we were told, you know, the lips can swell and that can totally throw off those things. But if that is the hospital policy, that is the hospital policy. We're not there to say, well, this is how you're supposed to do it. You know,
This is
they should be doing that research in what is present. Another example is like QBLs and EBLs, right? Quantity blood loss versus estimated blood loss. And the best thing to do is quantity blood loss, right? But some hospitals still don't. One of them is one that I was at, and I was like shocked that I was in the OR and we were doing, they were doing EBLs. I'm like, you guys don't do QBLs. And they're like, no, we know that we should, but that's just how it is. It runs here. It's just how they do it. So try to remain non-judgmental or like overstep your boundaries as a student nurse. But also it's really good to question things in your own mind. And it'll make you a better nurse and use your autonomy. So Sherrice, we're at the point of practice questions. So